listening to KZUM News on 89.3 KZUM Lincoln and KZUM HD. Good afternoon and welcome to today's edition of KZUM News, an hour dedicated to learning more about what is going on in Lincoln and the surrounding areas. I am the news director and your host, Amantha Dickman. And thank you for tuning in to today's episode of KZUM News. I'd like to start our morning with an update on last week's coverage of Legislative Bill 140. And if you didn't tune in during our fund drive, here are the basics you need to know. The Nebraska Legislature's Education Committee heard Legislative Bill 140 on Tuesday, February 4th. Introduced by Senator Rita Saunders at Governor Pillen's request, it aims to ban student use of electronic communication devices, such as cell phones, on school grounds or while students are attending a school instructional function. If adopted, all of Nebraska's 245 school districts would need to adopt device-related policies to conform to the law by the start of this fall. Since then, we've gotten more information regarding the outcomes of that hearing. It was announced on Tuesday, February 11th, that Legislative Bill 140, with Amendment 203 implemented to adjust the language of the bill for clarification, was placed on the general file. The bill will proceed to the floor of the legislature. A date for the debate is not yet available, but we will let you know once we have more information. And with that, we are turning our attention to a different bill that is currently under consideration. Legislative Bill 374 was initially heard by the Health and Human Services Committee on Wednesday, February 5th. Introduced by Senator Ben Hansen of District 16, the bill would create a procedure in Nebraska law for licensure of certified midwives. Currently, only certified nurse midwives are authorized to practice in Nebraska, and they may do so only in a hospital or birthing center and under the supervision of a licensed practitioner. Individuals who hold a CNM credential must be licensed as a registered nurse and complete a nurse midwifery education program. LB 374 would alter Nebraska law by adding certified professional midwife as a new category of state licensure under the Uniform Credentialing Act. The bill would create a board of licensed midwives and a CPM licensure process. It would also expand service opportunities. According to the bill, a licensed CPM would be authorized to attend physiological childbirths and provide prenatal, postpartum, and newborn care for up to 6 weeks after the birth. Senator Hansen, after opening on the bill, answered some of the questions the Health and Human Services Committee had on the potential risks and benefits the passage of LB 374 might have for Nebraskans.
We are up to LB 374. And Senator Hansen.
My name is Ben Hansen, that's B-E-N-H-A-N-S-E-N. I represent District 16, and I want to thank you for the time this afternoon. As you can tell, the bill I am presenting today is a popular topic, not only for the people in my district, but in yours as well. LB 374 creates licensure for certified professional midwives, a profession recognized by 37 other states. These midwives practice around the country in birth centers and homes, providing quality care to women and babies. I brought AM 152 to clarify that we are discussing professional midwives. I also didn't want to mandate coverage by insurance companies, so AM 152 addresses this. I also want to mention that I'm working with the Nebraska Hospital Association to clear up some language that may address any liability issues and to clarify that professional midwives don't claim authority in the hospitals. I've been hearing from people all over the state in support of LB 374. The support has come from parents, mothers, doctors, NICU nurses, EMT responders, professional attorneys, social workers, and many more. One NICU nurse said she has been working in the hospitals for 36 years, but she had all 4 of her kids at home. Some of the greatest support comes from Nebraska's certified nurse midwives. These midwives that are already trusted and licensed in Nebraska working in our hospitals. They also recognize the qualifications of their fellow midwives who are certified professional midwives. You will hear from certified professional midwives today, but something you should keep in mind is that this is not a new concept. This is not an experiment. Medical communities, governments, HHS departments, cultures, religions, and lawmakers all across the country find what we will be discussing today as normal. Planned home births have increased by 60% over the past 7 years in the United States. According to the Journal of Pediatric Medicine, the number of home births reached 46,918 in 2023, the highest in 3 decades. LB 374 is modeled after our neighboring state, Iowa. They created licensure for certified professional midwives in 2023 and are finding great success. These midwives are trained, skilled, and certified through nationally credentialed entities. With LB 374, Nebraska would become the 39th state recognizing certified professional midwives as knowledgeable and skilled maternity care providers. CPMs receive certification from the National Commission on Certifying Agencies with standards that are consistent with the standards for educational and psychological testing. These same standards are applicable to all professions and industries, including nurses. The certification options are respected nationally and recognized by the State Department of Education. So not only is this common in the United States, it is educated. Students demonstrate knowledge in clinical or didactic settings for over 800 topics related to birth. Skills exam, a 7-hour written exam, over 100 prenatal exams, 55 births, 40 newborn exams, 40 postpartum exams under the supervision and evaluation of a qualified preceptor. Most importantly, identifying risks throughout the pregnancy is a large part of their studies. I know that's kind of a concern a lot that I've been hearing from the opposition, is that they don't have the ability to recognize when something is outside of their scope and how to refer them. But identifying risks throughout the pregnancy is a large part of the studies. Currently, with more than 2,857 active credentials, 1 in 5 midwives in the United States is a CPM. National Library of Medicine studies aligned with the National Academy of Medicine to find that planned home births have outcomes comparable to birth center deliveries for low-risk birth. Professional midwives not only nurture normal birth processes, but are trained in risk assessment. Every CPM must have an informed consent document that details her relationship with referral physicians. Home births are legal in Nebraska with close to 100 births a year. In 2016, the state even had a proclamation stating that home births are a parent's right and that they are a safe option. In the opposition, you'll hear concerns. You will hear medical personnel saying that professional midwives aren't trained, that they aren't responsible, that Nebraska should be concerned. But I would point you to the handout that I provided you earlier. You will notice that more states have licensed professional midwives over the years, not less. You will also find that the training is nationally accepted as reputable, and the education required in LB 374 is consistent with other states. In most of the other states, home birth and licensed professional midwives are influential and respected in the birthing communities. Medical personnel work with professional midwives, not against them. Professional midwives work with the doctors, sending clients to them in cases of high risk. It is time Nebraska catches up. There will be people following me who are more knowledgeable about professional midwives. I have worked with the National Association of Certified Professional Midwives, North American Registry of Midwives, and the Nebraska affiliates of the American College of Nurse Midwives to craft this bill. I will answer any questions to the best of my ability, but the professional midwives following me might have more insight. With that, I thank you for your time and I ask for your support of LB 374. Thank you.
Thank you. Questions? Senator Frederickson.
Thank you, Chair Harden. Thank you, Senator Hansen, for being here and for your bill. Can you help just educate the committee a little bit? I know there's 2 separate bills that you're bringing related to, I want to say right, midwifery, I think is the correct word.
Your favorite term that you've learned,
midwifery,
yeah.
Yes.
Midwifery.
I know this bill, as I understand it, is with CPM, Certified Professional Midwives. There's also a second bill, as I understand, for
Certified Nurse Midwives.
Can you differentiate those two for the committee a little bit, or educate us a bit on the difference between the two?
In a nutshell, and some people behind me might be able to explain it better, certified nurse midwives are the ones that work in or with the hospital and birthing centers. Certified professional midwives will be more with home delivery.
Got it, okay. And are you able to speak more to the training requirements for a CPM?
Yeah, like the CPMs in general?
This one, yeah.
The handout has actually some better, it's right there in that green section on the left, on the left part. That explains a lot of the training right there for you.
Okay, okay.
Any other questions? Senator Reapy.
Thank you, Chairman. Thank you, Senator Hansen, for being here. You had said 60% increase in, was that home deliveries?
Yes.
When you're starting? Do you know, what percentage of all deliveries, do you know this, are home deliveries? Say any given year, like 20, any 12-month period of time?
I do have that information.
You have a big notebook there.
Yes, I like to have as much as I can. What percentage?
I was just trying to get some feel for the magnitude of it, whether it's, I'm also concerned with, is it trend, obviously, it appears it's trending somewhat because of the number of states that are involved.
Yes.
But I'm just,
If not, I'll get them in my closing, or I can get to you afterwards, one of the two.
okay, I'm just concerned whether it's 5% or 10 or 8 or whatever. Thank you. Thank you, Chairman. Thank you.
Thank you.
Other questions? Senator Ballard.
Thank you, Chair. The proposed bill creates a board under midwifery.
Midwifery.
What is the board responsible for?
Similar to what other kind of boards, like the Board of Dentistry, the Board of, cosmetology, all different kinds of boards that we have. It's kind of the oversight and current rules and regulations, training when it comes to midwifery, certified professional midwives, for instance, and more of a kind of an oversight approach.
Okay. So it'll still be regulated by the department. It's not a.
That's my understanding, yes.
Okay.
It's still in the Uniform Credentialing Act.
Yes.
So just like all
it's
those
the
other ones that are in
UCC.
there
Yeah, of
that we
course.
have.
Of course. Okay. And if I have one more question, if I may. So if an individual opts not to give birth in a hospital, is there other avenues besides, or is it hospital? Because I know Lincoln had a birthing center, so would this be your only other option? This home birth besides
Home
the
birth,
hospital?
yeah, birthing centers. I mean, one of the goals is to, I think that might be more the certified nurse midwives bill that we have coming up here. Probably, I don't know when we have it scheduled, but sometime soon here. We'll discuss that a little bit more about birthing centers and affiliation with hospitals, certified nurse midwives. I think that's kind of a direction we'd like to increase as well.
Okay. Thank you.
Senator Frederickson.
Thank you, Chair. Thank you for pointing me out to the handout. I saw in there a little bit. So my understanding from the handout is that part of the training is the requirement of attending or observing 55 births. Is that your understanding as well?
Yes.
Okay.
7-hour written exam, 100 prenatal exams, 55 births, 40 newborn exams, 40 postpartum exams.
Okay.
Under the supervision and evaluation of a qualified preceptor.
Okay. So one concern I might have is your typical OBGYN, by the time they're done with their training, typically deliver around 1,000 babies. There seems to be a really big discrepancy between the two there. Do you have any thoughts on that?
I think a lot of it is in the scope of practice as well, of what an OBGYN can do and a midwife cannot do. And that's where a lot of that training comes into, effect, especially when it comes to more emergency management.
Sure.
Which is what we're hoping, the whole goal is to have, which I think we do already. But in writing, CPMs now are qualified, regulated, licensed to recognize those kind of instances and send them then to the appropriate healthcare professional to address those emergency management situations in which they're trained in.
Sure.
Right? Midwives aren't trained to do C-sections, right?
Sure.
But they need to recognize when that needs to happen and send them to the appropriate person,
Okay.
which is what all their training is about.
Okay. And I also see here that there's, with the CPM, 6 weeks post-birth care. Can you tell me more about that?
Let's see, we have that in the bill here. It's just their ability then to kind of follow up with the child, make sure that they're healthy and happy, all that kind of stuff. Again, recognizing issues that are not within their scope, saying, hey, look, there might be concern that I have with this child. I would refer them to go see their pediatrician, right?
Okay.
Where a parent might have questions about that. I think that just creates another avenue, especially in kind of rural parts of Nebraska.
Sure.
Where they may not have those avenues.
Sure.
They can recognize this kind of stuff and then direct them where they need to go.
So that's more of like a consultation in tandem with like a pediatric type of setting, or?
Yes.
Should there be? Okay. My last question is, I see in the bill too, authorization to administer various drugs, including misoprostol. I know we have a bill in here next week that's looking to strongly regulate that drug.
You might be
Do
thinking
have any-
mifepristone.
No, I'm thinking I think both.
And
yeah,
misoprostol?
Misoprostol, yeah.
Yeah, from my understanding, again, somebody after me might be able to answer these questions better, but this is more they're not able to prescribe them, but they're able to use them in an emergency setting if they need to.
Okay,
Like,
so,
if they're in rural Nebraska and you have somebody hemorrhaging and your next pediatrician is an hour away,
right.
I mean, they need to have some kind of ability to handle the situation.
Right.
Again, somebody behind me will be able to answer that a little bit better.
Okay, so with that assumption, would you agree it'd be safe that misoprostol is a safe drug to utilize?
Depending on the situation.
Okay, but we're saying someone who has not been board certified could administer this.
I would have to know the administration of it to
Okay.
answer that question better.
Okay, thank you.
Senator Reapy.
You're able to see out of the corner of your eye.
I
obviously.
raise children too.
Thank
Yes.
you, Mr. Chairman. I don't want to wordsmith too much, but in the documents, it refers to, it says, according to the appropriate standard of care. I would like to see stronger language that says established standard of care. Appropriate seems to me maybe more judgmental, and I think that's dangerous in the healthcare business.
Yeah, and just like working with the hospital association to clean up liability language, I'm willing to work with anybody to see what kind of language we need to clean up to improve the bill. So I'm not against that at all.
And I know the providers are wanting to provide the best care they can too. There's no malpractice interest here. Thank you
Yep.
very much. Thank you, Chairman.
Senator Quick.
Thank you, Chairman Harden. So one of my concerns is, I guess, of course, my wife, Alice, was a labor and delivery nurse for 44 years, so she saw a lot of deliveries. I think she was in on maybe 40 to 50,000 deliveries throughout her career. So, and one of the things that, when I've talked to her about maybe this type of bill, she understands that maybe women want to have their births at home, but when she's seen a lot of situations where things go wrong, and it's not something that you can pre-assess before the delivery happens. So one of my concerns is it's not just the care for the mother, but after the baby is born, sometimes they have to go right to have a nurse there just to care for the baby, and then you have the nurse that's caring for the mother. You might have two nurses caring for the mother and one for the baby. So are they going to have that ability to make sure that they can take care of both? Because at some point they may have to be trying to care for both. So.
That might be a better question for somebody after me. I have the statistics on the difference between home birthing and births in a hospital, which I can allude to later. But that might be a better question for somebody after me.
Okay, all right, thank you.
Other questions? Will you stick around for
Definitely.
closing?
Yes.
Thanks.
Several folks showed up to testify at the Health and Human Services Committee hearing for LB 374. Bethany Vanderhart, a certified professional midwife, testified in support of LB 374, noting that CPMs are experts in out-of-hospital births and provide options for families who want the opportunity to give birth in the comfort of their own home.
Hello, my name is Bethany Vanderhart, Bethany Vanderhart. Thank you for seeing us today. I am a certified professional midwife. I have an associate's degree in direct entry midwifery from Southwest Wisconsin Technical College. I did 3 years of hands-on training with 5 midwives in both Wisconsin and Indiana. Both of these states offer their residents easy access to different midwifery options. I have worked in these states, both at home and in freestanding birth centers, and if I continued to live there, I would be able to get a license to practice freely with the credentials I have, which is why I asked you to pass LB 374. I am currently in the position to need midwifery options myself. I could legally do it at home, alone, with myself and my husband, but personally don't believe that is a safe option for me. Whereas if I lived just 10 miles to the east, I could have a home birth freely attended by a midwife. Why is Nebraska withholding from me a trained, qualified provider? But there is a way. A CPM is exclusively trained in out-of-hospital birth. She carries equipment needed to safely handle minor complications, has the knowledge to know when a safe, low-risk birth stops being so, and needs additional care. When that CPM is given the freedom to practice within her scope, she can also help to facilitate a safe transfer to the hospital. A large prospective study published in 2005 by Kenneth Johnson and Betty Ann Davis looked at over 5,000 women and found that planned home births for low-risk women using CPMs were associated with lower rates of medical interventions and had similar intrapartum and neonatal mortality to that of low-risk hospital births. A large part of the CPM's training requires risk assessment, and with this bill, we look forward to the chance to be able to consult with doctors, OBGYNs, or MFMs when a client is presenting prenatally with the potential to risk out-of-home birth. While I strongly believe that the majority of birth is a normal physiologic process, there is need for higher care sometimes. Licensure would enable the safe standards for competency-based CPMs to be upheld and gives prospective clients a way to verify the midwife they choose for their care. I started out mentioning Wisconsin and Indiana. Wisconsin passed licensure in 2010 and Indiana did in 2013. By quick Google search, both capital cities have over 10 different midwifery options, both CPM and CNM. Nebraska has none. Hospital with CNMs, yes, but no birth centers and no home birth options. Our state seal boasts equality before the law. Where is my equal protection, and where are the parents' equal opportunities? Thank you.
Thank you. Questions? Senator Frederickson.
Thank you, Chair Harden. Thank you for being here and your willingness to testify. Can you elaborate a little bit more? I asked this a bit earlier from a testifier about the 6-week kind of post-birth care that a CPM might be able to provide or might be able to assist with.
So the postpartum period would be the first 6 weeks after birth. And at that time, a lot of the assessment would be to assess the mother's bleeding, making sure it's continuing to be going down. We would be talking about breastfeeding, making sure that has been established and that that's going well. Able to take blood pressures, maybe able to diagnose if something's going to happen in the postpartum period that then we could transfer into care. We are able to offer the mothers who choose midwives a safe place to ask questions and get support and know whether or not what they're experiencing is normal or whether it needs maybe additional care.
Sure. So is the care at that point primarily for the mother, or is that for the baby as well?
Both.
For both as well.
Yeah.
Okay.
So it does not take place of a pediatrician,
Okay.
but for low risk mothers and babies, it's just more of assessment, making sure, and also weighing the baby, making sure that the growth is happening within that time period. And at birth, there's a newborn exam that is done by midwives usually, and that assesses whether or not all the functions are working the way they should. Weight and looking at bowel sounds and heart tones and respirations, looking over the skin and everything. And if anything happens at that time where we can assess that this baby needs additional looking into, then that's something that we can refer the parents on to a higher level of pediatrics.
Sure. My other question would be during an actual birth process, is there a way to monitor, for example, fetal heart rate, or I'm thinking of cases that I know in my own life of friends who've had very healthy pregnancies and then come to labor time, an umbilical cord was maybe wrapped around the infant's neck or situations like that. Can you walk me through that a little bit?
Yeah, the midwife will carry a handheld Doppler, and prenatal care is usually about an hour long for home birth midwives. They assess the mother's blood pressure and diet and her health, and they're checking out the baby as well, using fundal measures and making sure the baby's growing according to the weeks that she should, and then checking fetal heart tones. And with the Doppler, being able to listen for about 60 seconds is able to determine whether or not that heart rate falls within normal standards, and if there's anything that sounds out of the ordinary or it's not reassuring, then that's something where we would encourage the parents to go in, maybe get an ultrasound or something to figure out why. And the same is true with labor. So the midwife comes when the client calls, and also carries the same device. We check blood pressure, make sure everything is stable at the beginning of labor, and make sure baby is continuing to do well. You mentioned, cord around the neck. That is common, but it is actually not a common cause of death. About 10 to 29% of all babies are born with a nuchal cord, and most are not associated with perinatal mortality. It is, like to reiterate, not a common cause of fetal demise. And a midwife, at birth is able to, train to recognize the signs of that and help to facilitate the baby. If it does compromise the baby, then that's where she would use her NRP training to be able to help resuscitate while, figuring out what the next level of care would be.
Thank you. Senator Quick.
Thank you, Chairman Harden. So, and talking about like the fetal, the heart monitoring, I know in the hospital setting, my wife, I know they have a monitoring strip, so they're always monitoring. How do you monitor all the time? I mean, because you probably have to hold that on there, right? So how does that work? So
in a low-risk birth, there does not appear to be the studies that show that continuous fetal monitoring is necessary. I'm not speaking today for high-risk women, but for low-risk women, it seems that intermittent auscultation is enough to be able to figure out whether or not the baby is continuing to do well. It's a longer period of time in between checks in early labor. By the time labor has gotten to the period where we are in second stage, it is about every other contraction that we're listening in.
Okay, and then in the case of a shoulder dystocia where the head is out, I know my wife has talked about they've had several nurses in there to help reposition that baby to have a safe delivery or get that baby out, and that's still difficult. So what do you do when it's only you and you need other people to help position that mom so you can get that baby repositioned?
Right. So as Heather had mentioned, sorry, I just blanked. Most midwives work with an assistant, and we work with someone who can help us. The other person in the room is the dad. They can also help. The benefit of having an out-of-hospital birth is that women are not confined to a bed, and they are not under epidural medications. There is free movement, and when there's free movement, then the mother can change positions, and that can change the hip angles, and that can help work out the baby, or midwife is trained, if that doesn't work, to move her into a position that would to extract the posterior arm, to go into a lithotomy position if necessary, to use suprapubic pressure, things like that.
Okay, and then my last question would be on the postpartum. So, some mothers going to have postpartum depression. So, do you also treat that, or what do you
That
do?
is the benefit of postpartum care, because we are able to come into their homes when they are recuperating as an outside person looking at their life and able to see whether or not that they are doing well. We ask questions about how are they doing, how is their mood, what are their emotion levels like, and if it's just a minor case, we can talk through that. Sometimes all it needs is just talking to someone else to help with some of the postpartum hormone changes. Other thing is nutrition is benefit to the mental state of people. And so if it is not, and I know some midwives also will go through a postpartum depression checklist, and they'll kind of use that as a screening tool on their patients and decide whether or not then they would need to go see a therapist or someone else who's trained more specifically into that.
And you can refer them to that then? Or?
Personally refer them, at the place where I have worked, I have not had the ability to, like I said, sign anything over. But it would be the same that they would, call up a person and request to be, seen by them.
Okay, thank you.
Other questions? Seeing none, thank you for being here.
Again, that was Bethany Vanderhart, a certified professional midwife, testifying in support of LB 374. We're going to take a quick break, hear from our underwriters. When we come back, we will hear from a few more proponents and opponents of LB 374. Stay tuned to learn more, and we'll be right back.
Support for KZUM comes from Lincoln Pharmacy, a local neighborhood pharmacy located at 33rd and A Streets, offering medication therapy management, medical supplies, citywide prescription delivery, vaccinations, and more. Open Monday through Friday from 8:30 a.m. to 6 p.m. and Saturdays from 10 a.m. to 4 p.m. More information at lincoln-rx.com.
And from
No Coast Roller Derby, a skater-owned and operated nonprofit organization since 2005. The opening event of the 2025 season is February 22nd at the Lincoln Sports Foundation Complex at 7600 North 70th Street. Doors open at 4 and the bout starts at 5 p.m. Tickets and more information are available at nocoastrollerderby.com.
For 50 years, CenterPoint has provided mental health and substance use services in Lincoln. In 2020, CenterPoint added primary care services, and now they are expanding with their new campus for health and well-being. At the campus, primary care offerings are available for all ages, whether you are enrolled in the CenterPoint programs or not. Services include immunizations, women's health care, STD testing, allergy management, physicals, and sick visits. CenterPoint has low and no-cost options for those who are eligible. Appointments may be scheduled by phone at 402-475-5161. More information about CenterPoint services is available at www.centerpoint.org.
And welcome back to today's episode of KZUM News. My name is Samantha Dickman, and I am your host for today. Before the break, we were learning about Legislative Bill 374, which was initially heard by the Health and Human Services Committee on Wednesday, February 5th. Introduced by Senator Ben Hansen of District 16, the bill would create a procedure in Nebraska law for licensure of certified midwives. Currently, only certified nurse midwives are authorized to practice in Nebraska, and they may do so only in a hospital or birthing center and under the supervision of a licensed practitioner. Individuals who hold a CNM credential must be licensed as a registered nurse and complete a nurse midwifery education program. LB 374 would alter Nebraska law by adding certified professional midwife as a new category of state licensure under the Uniform Credentialing Act. The bill would create a board of licensed midwives and a CPM licensure process. It would also expand service opportunities. According to the bill, a licensed CPM would be authorized to attend physiological childbirths and provide prenatal, postpartum, and newborn care for up to 6 weeks after the birth. Before the break, we heard from Senator Hansen as he opened on the bill, and from Bethany Vanderhart, a certified professional midwife, who expounded on the fact that CPMs are experts in out-of-hospital births. Gabriella Otto also spoke on Wednesday, February 5th in support of the proposal. During her testimony, she explained the importance for women of color to have access to various birth options, citing data from the Centers for Disease Control and Prevention that indicates Black women in the United States are 2.6 times more likely than white women to die while giving birth in a hospital.
Welcome. Hello. My name is Gabriella Otto, Gabriella. I appreciate you taking the time to hear me out today.
And last name is O-T-T-O?
O-T-T-O, yes.
Okay, thanks.
I am asking for your support of LB 374 and helping mothers like myself have the option for birth in a place that is safest for us. First, I'd like to draw attention to the fact that we are not talking about some medical phenomenon. Birth is normal. So normal that every one of us has experienced it in some way or another. Birth also happens every day. It isn't rare. And finally, birth is cultural, for me especially. During my first pregnancy, at my very first appointment, with an OB, my OB would hardly look my way, a legal adult, instead turning all of my questions to my mother. I was frequently asked to run extra tests during this pregnancy just in case, because since you're of color, there are extra risks. One time, she went as far as suggesting I schedule an abortion due to my inconclusive test. No other testing was done at this time. We later found out towards the end of my pregnancy that all those testings were within normal ranges and it was a lab error. When I did bring up fears or questions, they were regularly dismissed and or ignored. My whole experience during that time, including my labor and delivery, I had no real choice in providers or any questions being asked. I was made to feel ashamed and on edge, ready for my body to fail me at any moment because of my skin color. Since then, I have realized that I am not alone. It doesn't take much research to know that Black women in the United States have higher risks of maternal mortality. The CDC says Black women are 2.6 times more likely to have higher risks of more likely to die in a hospital giving birth than any white woman. In fact, when a mother of color has a birth in a hospital, they are told this statistic. I appreciate the care given in our hospitals, but in birth, sometimes we are looking for something else. Through my experiences, I decided I would become an educated doula and work to support women during birth. It comes at no surprise that according to recent data, the rate of home births among Black women has significantly increased. I saw a CNN report that says studies that show a jump of over 30% in recent years, indicating a growing trend of Black women choosing to deliver at home instead of a hospital setting. As a birth worker, I can say that Black mothers have a desire for more control over their birthing experiences, and the home birth option is working for us. People all around the country are finding the care we need. If you look around at the policies in other states that not only allow but encourage for home birth, it would suggest that home birth is normal. It happens every day and is culturally acceptable everywhere but Nebraska. My second birth was at home. I was respected. I was not told that my color was an issue. I was told I was powerful and capable. I took responsibility. This is how we should approach birth. I am asking for professional midwives to be respected as qualified birth workers in Nebraska. Please support LB 374. Thank you.
Thank you. Questions? Seeing none, thank you.
Thank you.
Another proponent.
There were several opponents who testified in opposition to LB 374, citing concerns about how this bill might impact families facing emergency medical situations during birth. Amy Pinkall, a pediatric physician who testified on behalf of the Nebraska chapter of the American Academy of Pediatrics, said that the lack of medical training required to become a CPM is a concern when it comes to situations that might pose a threat to the safety of the parent or the child.
Opposition to LB 374. Welcome.
Hello, thank you for your continued patience, Senator Hardin and committee. My name is Amy Pinkall, A-M-Y-P-I-N-K-A-L-L, and I'm a physician testifying on behalf of the Nebraska chapter of the American Academy of Pediatrics. As a pediatric hospitalist physician, I provide medical care for newborns in the hospital setting. My testimony will focus on the bill's impact on newborns. However, provisions of this bill do not ensure safe and appropriate care for newborns nor their mothers. Certified professional midwives, also known as direct entry midwives, lack adequate training to safely handle the unexpected risks and complications of managing labor and delivery and the care of newborn infants. The American Academy of Pediatrics, the AAP, does not recommend planned home birth, which has been associated with, as we just heard, a twofold to threefold increase in infant mortality in the United States. Rates of mortality for infants delivered at home by lay midwives is even higher. Mortality for infants delivered at home by lay midwives is up to fourfold higher than those delivered in the hospital. AAP policy dictates that 2 care providers should be present at each delivery, and I think other testifiers have touched on this, and at least one of these providers should have the primary responsibility of taking care of the newborn. They need to have the appropriate training, skills, and equipment to perform a full resuscitation of the infant according to the neonatal resuscitation program. Approximately 10% of deliveries of full-term infants require some degree of resuscitation. So having trained, skilled providers that are able to assess infants and intervene immediately when necessary is of the utmost importance. This bill does not ensure the CPM would have the necessary skill set to resuscitate a newborn. This bill would allow direct entry midwives to provide care for the newborn immediately following birth and for up to 6 weeks after birth without any medical training or degree. It is a critical time in a baby's life. They are at risk for a multitude of conditions, such as hypoglycemia, low blood sugar, hyperbilirubinemia or jaundice, sepsis, and congenital heart disease. This bill does not ensure the CPMs have the medical knowledge, skills, or training to recognize and promptly treat these conditions. This bill is unsafe and puts at risk the lives of our smallest and most vulnerable newborns. Thank you.
Thank you.
Any questions?
Questions? Senator Quick?
Thank you, Chairman Hurd. So I know you heard me talk a little bit about like the baby care. And so I know like usually in the hospital setting you would have a pediatric nurse, a labor nurse, then you have also that pediatric doctor and a doctor for the mother themselves. So I know sometimes there's a family practice doctor that can do both, but that training to take care of both of those is, I think, vital. So I don't know if you can talk a little bit about the training.
Right. So, and I think it's important that it needs to be more than one person that has that capability for taking care of mom and baby. You can't have one person who's capable of both, because sometimes they're both needing care at the same time. In the hospital setting, we have sort of different levels of attendance at deliveries based on risk of moms, but there's always someone there whose only job is that baby and to be able to resuscitate that baby. If there are problems, then of course they call and a whole team of people comes to assist. But they have, a checklist of equipment that they look at before delivery to make sure that they are able to intervene in any way necessary immediately after that baby's born.
Thank you.
I know I'm asking you to speculate a bit. How many times does that doctor of the baby need to rush that baby off because there's a complication that is quite disconcerting, requiring special care of some kind that would not be safe if the baby was born at home? How many times out of 10 might that happen?
10% of deliveries require some intervention, and sometimes it's pretty minimal intervention. And I don't know the specifics. I think it's closer to 1% for significant intervention, CPR type things.
Okay, that's helpful, thank you.
That's what the neonatal resuscitation program quotes, I believe, is 1%.
Okay, other questions? Seeing none, thank you. Opposition to LB 374.
Maggie Coleman, a maternal medicine physician, shared some of those concerns, detailing some situations in her work where close monitoring in a hospital was a necessity for the safety of parent and child alike.
Other proponents, we'll come back to you we gave the first group an hour and a half. We're going to switch back in an hour and a half if we have that many opponents. And so here we go.
Thank you, Senator Hardin and other members of the committee for hearing my testimony. My name is Maggie Kuhlman, MaggieKuhlmann, and I am a maternal medicine physician, MD, at the University of Nebraska, though I'm not representing them in that capacity. And I am here to voice strong opposition to this bill. I have a lot of issues with it, actually, but I will hit on 3 points. The biggest of which is the idea of preventable harm. There's been a very dangerous hand-waving argument that has been proposed here that complications of birth occur in any setting. While that is technically true, it is also wildly misleading. Common complications of birth, including postpartum hemorrhage, infection, hypertensive disease of pregnancy, and birth trauma, look a lot different in out-of-hospital births versus those in hospitals with resources, highly trained professionals, and numbers, right? You've alluded to that point. Okay? There's also the idea of, I keep coming back to comparing my own training and my own requirements for licensing in the state of Nebraska versus those that are proposed in this bill. And although the idea of regulation has been put out there, it's extraordinarily vague. And a lot of the safety measures that my profession goes through to ensure safety to my patients, like continuing medical education, are not addressed at all in this bill. Another idea I would like to turn to is the idea of misuse and abuse of the wide scope of practice that is actually granted by this bill. A lot of people here have testified, and I've talked to a lot of people who have told me, you know, they don't like to think of birth as a medical event. There's even a section in this bill, Section 20, that posits that certified professional midwives are not engaged in the practice of nursing or medicine. If that is true, I don't know what placing IVs and giving medications is supposed to be. That's the way that I practice medicine. Nurses spend a lot of time not only hitting a vein in a practice setting, but learning how to deal with complications, learning how to recognize them. And Senator Quick, as your wife can probably attest to, it's a lot harder to hit a vein after someone has lost 4 liters of blood and is actively hemorrhaging than to do it in a practice setting. The medications that are specified in this bill, methylorgonavine, that is a medication that you cannot give to someone who is hypertensive. If you're not doing serial blood pressure monitoring, how do you detect preeclampsia, a common complication even in low-risk women? Okay, so I can't support this bill. I don't think it is in the best interests of women and babies in the state of Nebraska. And, you know, I practice not only in Omaha, but in outstate Nebraska. I was in Grand Island yesterday. And although I do not doubt that there are physicians who may be enthusiastic collaborators for out-of-hospital births, I have yet to meet one. That's it.
Thanks for being here. I have a question. Help me understand. 37 states do allow this, and what are they thinking? From your perspective, can you comment on that for me?
Honestly, I can't. I don't understand it.
Okay. It seems absurd to you. You've seen it all.
Yes, I have. I've seen complications of out-of-hospital births, not only here in Nebraska, but I actually did my training in the state of Texas, where direct entry midwifery is legal and allowable. And throughout my 7 years there, I saw a lot of bad complications, including maternal and neonatal mortality.
Okay. Other questions? Senator Frederickson.
Thank you, Chair Harden. Thank you for being here and your testimony. You talked about direct entry midwifery. Do you have any thoughts on the certified nurse midwifery?
Yeah, I work with certified nurse midwives in my practice. I have from my training to, actually I was with CHI before I went to the University of Nebraska. And that's another thing, you know, I've seen people who are very happy with working with certified nurse midwives. I understand that people seek different models of care, and I support people in doing so. But the problem with birth is that things go wrong even in low risk women, and resources need to be on hand.
Thank you.
Other questions? Senator Quick.
Yeah, thank you, Chairman Harden, sorry. So, you know, I know you heard some of the questions asked previously about, any delivery, you know, you may not know until that baby's actually coming that some of these problems are going to, you know, some of the risks that are involved. So let's just say like an abruption. Well, I mean, how much time would they have to get to a hospital? Because you're not, I mean, it's a short amount of time, right?
It depends. Abruptions can be, you know, occur slowly, or they can occur massively and all at once and cause fatal demise.
Okay. And then, you know, I know you've had years of training, right? So compared to the training that they would receive, compared to what you've had and what, like my wife, she went through, she was a diploma RN, she went back to the med center, got her bachelor's degree, and then hers, she had to get all of her certifications to be registered or a delivery nurse, and then also I think they had to do some for taking care of babies as well. Mm-hmm. So and then our continuing education. So
Great.
So can you address like the training that they're getting versus what you've had, and like my wife? I mean, it's a lot less, right?
I mean, I think like in obstetrics, like with most things, you have to be there to see things and to get training. So the more experience you have, the more structured education you have, the more continuing education you have to stay up to date on what evidence-based practice tell us are the best and safest things to do, the more qualified you are to do that.
Okay, all right, thank you.
I don't know if I answered your question exactly.
Other questions from the committee? Seeing none, thank you for being here.
The Health and Human Services Committee took no immediate action on LB 374. As such, we will provide updates to you as we receive them. And very quickly, as we are coming to the end of today's show, I do just want to take a moment and thank everyone who donated to KZUM News or to KZUM in general over the last couple weeks for our birthday fund drive. I don't always get a moment to stop what I'm doing and thank folks while I'm on air doing the show, just because you have to be very precise about where you are taking your breaks when it comes to organizing news information. So I always like to take some time and thank everybody for participating during our fund drive. It's really awesome that 3 times a year we can ask you guys to help us out. You know, it does cost something like a little over $50 an hour to keep us on the air. So the fact that we have so many people who love our station and help us reach that goal 3 times a year is fantastic. And for those who are looking for an update, last I checked, which was Friday afternoon, somewhere around 2 p.m., we were sitting about $250 away from our $30,000 goal, which is really close. I will say that one of our programmers did have his medal benefit last night, so we are probably now over that goal if I had to guess, because he does fantastic work and collaborations with local musicians, and he puts on a fantastic event every year, which is still going on. So if you're a metal fan, now's your time to go check it out. But thank you all again so much for helping us out, supporting our newsroom and our station. We really appreciate it. And with that being said, I'm just going to say have a lovely weekend. It's supposed to be warmer, and that's really all we could ask for after the last week. I hope you all can enjoy some sun before second winter sets in, and we'll see you next weekend. We are fast approaching the end of the hour, so here are your reminders for today. The KZUM Newsroom is always open to hearing about any questions, concerns, suggestions, or even any story ideas that you might want to share with us. All you have to do is give us a call at 402-474-5086, extension line 6. If you give us a call and we aren't available, don't forget to leave a voicemail. Or, if you aren't much of a phone person, you can also find our social media handles and more newsroom information at kzum.org under that About tab. Speaking of our website, if you happen to miss a show, you can always head to the KZUM News tab, where we archive all of our shows and include a transcript with links to that day's content. And lastly, I just want to give a shout out to Jack Rodenberg of the Rodenberg Music Experience. He put together all of the amazing original music that our news program uses. So once again, thank you, Jack. That wraps up our reminders for now. As you head out into the world, I hope you have a lovely day. Thank you for listening, and we hope you'll join us next time. You just finished listening to KZUM News, an original production of KZUM Radio that airs every Saturday at 11 a.m. Coming up next is Beta Radio, so stay tuned.